make sure that the presenters have maximal amount of time. It is being recorded, so you can pass it on to any that may miss this first portion. I expect many more to tune in. So welcome to the Critical Care Grand Rounds presented by our Ethics Department. The topic of futility, and even whether that's the right term to use, but as a concept, I think we all grapple with the challenges of wondering about this idea and what's the best action plan when we feel like we're starting to get into therapies that are not going to be beneficial to somebody. How do we deal with it in practical terms and gaining consensus among the team? So I'm looking forward to this for sure. So the utility of futility is what's the point? Dr. Grace Weed, Dr. Gina Mohr, and Dr. Jukes Namm are going to present, and joined by Chris Johnston from the legal team as well. So I welcome you to this Grand Rounds, and thank you so much for your willingness to present to us today.
Thank you so much, Dr. McCluskey. Thank you for this invitation. I speak for my colleagues here in that we are looking forward to having a good discussion, certainly after we present our material. I want to encourage all of those who are on here to ask your questions in the chat box. So the two of us who are not presenting will be answering questions in the chat box. And also, if you want to save your question toward the end, please do so. And again, we're looking forward to a lively question and answer session during the discussion portion. We have no relevant financial disclosures, but we do have an ethical disclosure, which is that there is no one-size-fits-all answer, unfortunately. Now, I don't know if you're a fan of demotivational posters, but I am, and this is really my favorite one. And the reason why I put it up here is because I have a confession to make. And my confession is that when I get an ethics consult about futility, or as we like to call it, potentially inappropriate therapy, or some may even call it medically inappropriate therapy, I start to get this feeling of despair. And likely this is because these cases about medical futility are amongst the most difficult ones. They usually require a hefty investment of emotional energy from everybody involved, and they may not be able to be resolved in a way that is at least marginally acceptable or satisfactory to all parties. These cases can lead to moral distress and clinician burnout, and I speak from firsthand experience as both as an ethicist and a pediatric intensivist that these are very difficult cases. So this is why I start to get a feeling of despair, because I'm afraid that it's going to go pitch black pretty soon. Now, I'm using some dark humor to explore the root causes of our discomfort in dealing with cases of medical futility, because, like I just mentioned in our ethical disclosure, there are no easy answers. There is no one-size-fits-all. There is no easy, well, if we had just done this, then we could have prevented the current situation. But I do think we can gain a lot of wisdom about ourselves, about our patients, and the way we practice medicine by delving deeply into the subject. And just like any subject, there are better ways to talk and think about futility, and this is what we'll do over the next hour together. Our hope is that after this talk, if you get this feeling of despair when approaching a case of medical futility, you won't feel like the lights are going out. You'll feel like it's dark, but it's darkest just right before the light dawns. During our talk today, we want to go through medical futility in the historical context and its limitations, recognize the importance of goals in our discussions with our families and our patients, and then provide some practical approaches of how to communicate during these difficult decisions. Now, futility is not a new subject. In fact, Hippocrates, the father of medicine, and perhaps the Hippocratic Oath, wrote about futility in his volume 2 of one of his treatises. He wrote, and I've put it here in the red box. he wrote about refusing to treat those who are overmastered by their diseases. So he recognized a central tenet that in certain aspects, medicine is powerless. We've spent the intervening 2,400 plus years since trying to define just what exactly medicine is powerless over. As I have already alluded to, there is language that different people will use when trying to talk about futility or medically inappropriate therapy. Now, the language will differ, but the concept is still the same. We're talking about the same thing when we talk about futility, medically ineffective therapy, potentially ineffective therapy, or simply treatment that we say is not medically indicated. What we're talking about is that there's a lack of consensus on what is or what should be considered appropriate treatments for the patient. We also may, in other words, we may differ in what we think which treatments are worth it for the patient. Now, our disagreements often center around an intensive level of care. It may center around invasive interventions. It may also take into context patient suffering and their perception of the quality of life of our patients. And for clinicians, it also does center around the distribution or the use of scarce resources. Now, I won't dwell on the multitude of articles that have been written and will likely be written in the future regarding the use or the disuse of certain words. I do think it's helpful to be precise in our language. I do think it's helpful to avoid using the term futility and instead use the terms medically ineffective therapy or potentially ineffective therapy. But I also recognize that the terms that we use now may fall out of favor in the future. Who knows? We may turn back to using futility in the future. But again, regardless of what terms we use, the concept is still the same. It reminds me of the saying, no matter how far we try to push the envelope, it'll still be stationary. Many of you may have heard myself or Dr. Namm or Dr. Mohr talk about how clinicians are not legally required to provide medically ineffective therapy. And you know, we have Chris Johnson who's going to provide us with a legal perspective at the end, but I do just want to quickly point out that this is a screenshot from the California Probate Code, and it says that a healthcare provider or healthcare institution may decline to comply with an individual healthcare instruction or healthcare decision that requires medically ineffective healthcare or healthcare contrary to generally accepted healthcare standard. So we don't have to provide medically ineffective healthcare. What is medically ineffective healthcare? Well, medically ineffective healthcare, as defined, is treatment that would not offer a significant benefit to the patient. Oh, okay. Well, you know, that actually sounds fairly simple. Maybe there is a one-size-fits-all. You know, maybe I've actually not advertised it correctly. If we don't need to offer medically ineffective therapy, and if we just stop using the word futile and then just label the label that treatment medically ineffective therapy, perhaps that is our answer. And you know, this sort of terminology is supported by consensus statements and guidelines from various professional organizations. This is a recommendation taken from a widely read article, a multi-society position statement about how to respond to requests for potentially inappropriate therapy. The citation is at the bottom. So again, now that we know what medically ineffective therapy is, we don't have to provide medically ineffective therapy. So then can we just not provide medically ineffective therapy? Well, let's try to apply it then to a patient, because I think once we start applying it to a patient, it becomes much messier. This is a 60-year-old female, and just 2 months prior to her current admission, she was diagnosed with advanced endometrial cancer. At the time of her diagnosis, she was not deemed to be a candidate for surgical resection or for palliative chemotherapy or radiation due to the extent of the disease that she already had and her functional status. Her family elected to take her home and care for her at home. And they brought her back to the hospital because she had not had a bowel movement for 6 days. She had not been really eating well for the past 3 days, and she had also been vomiting. So now her family was very concerned about dehydration and hypoglycemia. In the ED, she was noted to be quite altered, and just exhibiting some behaviors that did not make sense. And so her family, she had quite a number of family members around her. Her family took on the duties of making medical decisions on her behalf. In the ED, they had an abdominal and pelvis CT, which showed a large bowel obstruction from the tumor. They got consults from acute care surgery and gyn-onc, and she was deemed to not be a candidate for acute surgical intervention. Her family desired aggressive therapy, though, aggressive treatment, and so the patient was admitted to the MICU. Because of the concerns for dehydration and malnutrition, the patient was started on TPN. She was intubated on ICU day 2 for acute hypoxic respiratory failure. That evening, after she was intubated, she went into cardiopulmonary arrest. There was return of spontaneous circulation, or ROSC, after 2 rounds of CPR. The next day, she also developed cardiopulmonary arrest. She got 3 rounds of CPR, and ROSC was obtained. Currently, she is on high-dose vasopressor and inotropic support with progressively worsening metabolic acidosis and organ failure. So when we talk about medically ineffective therapy, at what point did her therapy become medically ineffective? At what point did medical therapy start to not provide benefit toward the patient? Significant benefit toward the patient. Was it the time of her diagnosis? Was it when she was admitted to the MICU or when TPN was started? Was it when she was intubated? Perhaps all of these were beneficial to her, but the CPR was not beneficial to her. Perhaps the CPR was beneficial to her, but right now her current level of treatment is no longer providing significant level of benefit to the patient. It becomes quite difficult to try to tell when treatment becomes when treatment becomes potentially inappropriate. When we try to define potentially inappropriate therapy, sometimes it can be hard to define a negative. So I find it easier sometimes to actually talk about what is medically indicated therapy. When do we know that it is good and proper and appropriate to provide the therapy? Well, there are 2 requirements for medically indicated therapy. The first requirement is that there is a physiologic benefit to the treatment that outweighs the physiologic burdens. And the second requirement is that the treatment advances the patient towards their goal for their health care. This is what I call the continuum of medically indicated therapy, with medically indicated therapy being on your left-hand side with the dark green, and therapy that is not medically indicated being represented by this black box here. Again, therapies in which the physiologic benefit is greater than the burden and the treatment advances the patient towards the goal, these are medically indicated therapies. And sometimes these therapies are so obvious that we really don't need to spend much time talking about the patient's goals or even the benefits and the burdens of disease. But as we start to have less physiologic benefit, this is when we start moving in the continuum towards the light green and then progressing towards the gray and finally to the black of our continuum. So let's go to the light green. What determines whether therapy is in that light green category? Well, the burdens are accumulating, right? The physiologic benefits are maybe equivocal, or maybe the physiologic benefits are felt or perceived to be even less than the physiologic burdens. But because the patient bears the physiologic burdens, they get to determine the acceptable ratio of their burden benefit. In other words, they get to determine whether the treatment is still worth it. So in here in the bolded section, physiologic benefit is equivocal or maybe even a little bit less than the physiologic burden, but the treatment also advances the patient towards the patient goal. So now this is the light green. What about the gray? When we start getting into the gray areas, What defines medical therapy in the gray area? Now, remember, there are two components of medically indicated therapy. There is physiologic benefits and burdens, and the second is that the treatment progresses a patient toward their goal. So now I want to focus on that first component, which is the physiologic benefits and burdens. If these are scenarios or situations in which it is unclear, or it may seem that the treatment actually does not provide a physiologic benefit to the patient or actually provides a physiologic harm. So in any of these situations in which the treatment seems to fit into these categories, this is where we would have these gray areas of potentially inappropriate therapy. So the first one, the treatment has no or little reasonable chance of producing the physiologic or functional effect desired. Second, the treatment causes disproportionate harm. Or the third one, the treatment has no realistic chance of returning the patient to a level of health that permits survival outside of an acute care hospital. Or this fourth situation, the treatment is contrary to generally accepted medical standards or established clinical guidelines. Again, if the treatment falls into any of these situations, you're in the gray zone. I would have to say that this is probably one of the more controversial ones because it seems that survival inside of an acute care hospital may be somewhat of a desired state. However, there is support from our professional guidelines. This is a guideline put out by or statement put out by the Society for Critical Care Medicine. And number 2 reads, ICU interventions should generally be considered inappropriate when there is no reasonable expectation that the patient will improve sufficiently to survive outside of the acute care setting. Let's talk about what situations would put you in the gray area in regards to the patient's goals for their health care. So if the treatment cannot actually get the patient to where their stated goal is, then it is in the gray area and potentially ineffective therapy. Or if that treatment will only serve to maintain the patient's life in a quality that is unacceptable, that is a situation in which, again, the therapy is potentially inappropriate. So we've talked about the continuum. We've talked about the two requirements for medical indication, which are physiologic benefit burden ratio and whether the treatment advances the patient towards their goal. As we get more, as that ratio between benefit and burden shifts, as the treatment no longer seems to advance a patient towards their goal, these are situations in which the therapy that the patient is receiving is medically or is potentially inappropriate or also can be medically ineffective. So these are the conundrums that really come up. What if the patient or the patient surrogate changes the goals? And the second question, can clinicians unilaterally refuse to provide treatment for situations in the gray area? Well, I would say for the second one, can clinicians unilaterally refuse to provide therapy? I do want us to think about when it would be okay and ethically acceptable and supported actually to provide potentially inappropriate therapy. And it's really based on a social contract. Society has empowered physicians with a monopoly to provide certain life-saving activities. Physicians should provide these services to society, even if an individual believes for these services to be inappropriate under certain conditions. Now, before you think to yourself, wow, that I'm not sure how I really feel about society telling me how to do my job, these regulations already exist. And just a brief example of these regulations, for example, state and federal regulations prohibit medical practitioners and clinicians from discriminating on the basis of race, national origin, disability, sex, exercise of conscience, religion, etc. So what are some conditions in which it can be appropriate to provide inappropriate therapy or potentially inappropriate therapy within the social contract. I would suggest that there are 5 conditions, and these are just slightly modified from Robert Veitch's article here in Perspectives in Biology and Medicine. If there is an ongoing physician/institution patient relationship, and the physician and or institution can provide the desired skill or service, and there's no other physician or institution who is willing or can provide that skill or service. Again, I think these conditions are very easily fulfilled. The next 2 are a little bit more difficult to understand. The 4th one, an equitable funding for the service. And what I mean by this, and what Dr. Veitch means by this, is that the cost of the service is not borne by the institution, but rather by a readily available funding mechanism such as insurance. And this is part of the social contract. So part of the social contract is that physicians will provide a certain service, and that service has deemed to be appropriate by a third party and a third party funding source, such as an insurance company or the insurance industry. So if there is an equitable funding for the service, then that is a condition, and the service falls under the condition, then that is an instance where it would be potentially okay to provide the therapy. The last condition is that the treatment preserves a known fundamental interest, such as preservation of life or appropriate relief of pain. What is an example of something that would fulfill all of these requirements? So the classic example would be a tracheostomy, ventilator dependence, and PEG tube placement for a patient in a persistent vegetative state. So you have a patient who comes in and they've had, or they suffered from global agnostic brain injury, and they have been treated at the institution. There's an ongoing relationship. There is a transfer to another institution has been explored but denied. Our institution can definitely provide this service. There is an equitable funding for the service, meaning that the insurance industry will go ahead and cover the cost and the treatment of long-term mechanical ventilation, and the treatment preserves a known fundamental interest, such as preservation of life. Thus, even though one may feel that this is potentially an appropriate therapy, it would fulfill the conditions in which it would be ethically permissible to provide that therapy. So then the answer to the question, can clinicians unilaterally refuse to provide treatment? Well, it depends. And it depends really heavily on that second requirement of defining, when we defined medically indicated therapy, which is that the therapy moves the patient towards their goal for their healthcare. And now I want to turn it over to Dr. Mohr.
Thanks, Grace. I hope that you can see these slides. Let me share here. All right. So I want to give some real practical examples about how to think about this. And one of the things we really focus on is talking to patients about goals of treatment. Often I hear a discussion about what interventions people want or don't want without first talking about goals. And when we do that, I think we do it backwards. Because it's important to know what the big overall goal is before knowing which interventions are going to help you achieve that or not, right? I mean, why even talk about dialysis if someone isn't even in renal failure? It's just a non-issue. So we need to look at goals first. And goals are really based on personal values. And values really don't have anything to do with medical determination. It really has to do with individual personal values. So we have to be careful with assumptions. I think one thing that folks often assume is that, well, everyone everywhere would always want any intervention to keep going no matter what. And sometimes you'll hear the question, what would you do if this were your mom? With the assumption that, well, clearly you love your mom, so you'd want to keep her alive, right? But I would say, if my mother was someone who said, I don't want to be on a ventilator long term, I don't want to do any more dialysis, I've had enough of this, then my answer would be, it really depends on what the values are of my mom and what her goals are. Because the answer is not necessarily, of course, do anything and everything. So true physiologic futility is pretty rare. I know I've been in a couple cases where we have seen this. We certainly talked about it in the era of COVID with people being on high pressor support and ventilator support, and then they go on to code and that CPR really would not benefit them. But it's pretty rare to have true physiologic futility. In fact, I have a woman, a 65-year-old with diabetes, hypertension, and a stroke who got COVID, developed respiratory failure. She's been on BiPAP, but not doing well. And she actually indicates that she wants this BiPAP off. And her family understand that she's not improving. And instead of saying, no, mom, you have to keep doing this, and we don't really care what you want, we want to keep interventions going, they actually say, we don't want to prolong her suffering, and agree to stopping the BiPAP. So we can't assume that everyone wants everything done. And I think really when we talk about futility, what we're really trying to explain are these 2 points, that there actually are limits to what medicine can do, and that humans are mortal. And I think these are 2 points that we often have a really hard time admitting to ourselves. Certainly our patients and families, I think, sometimes have a hard time dealing with these concepts. So let me give you another example. I see this quite a bit in my work in palliative care, where I see patients who may have a very advanced cancer. This was a young woman with a metastatic malignancy who came in multiple times for a GI bleed. And every time she required some blood transfusions, she had some embolization done. And each time she came in, whatever team was taking care of her said, you really should go home on hospice. And multiple times she said, no, I don't think I'm ready for that. And in fact, she had several admissions over the next 14 months where she felt she was still having an acceptable quality of life. She got more time with her family. And then on her last hospitalization, she developed liver failure from diffuse metastasis and said, now I'm ready for hospice. So sometimes it comes not on our timing, but this talk about goals of care is really a process. I think this is a question that many people ask. What do we do? What is our response when families ask for a miracle? And is this even a legitimate request? So I think really what they're asking for is often time. I think they know, and certainly we know, that we don't perform miracles. But I think what they're really asking for is, keep doing what you're doing because it's keeping mom alive. And then we're going to pray that God will heal them. So certainly giving people time is something actually within our ability to do. So I think don't be misled by this request for miracles. A 26-year-old man with a cardiac arrest due to a drug overdose, and he now has hypoxic brain injury. No significant improvement is expected. If you ask most Americans if they would be okay existing in a persistent vegetative state, most would say, if I can't interact with my surroundings and acknowledge that my family is there, I wouldn't want that. But certainly things like pegs, trachs, and vents can keep someone in this state almost indefinitely. We know that it won't improve his brain injury, but we know that it can certainly extend life. And for some, that may be a good enough goal. So as Atul Gawande often says, in his book, Being Mortal, he says, what are you willing to go through to get more time? And this is, again, a very individual question and answer. And it's an individual's values that will determine this, not necessarily a medical prognosis. Right. So if a family of the 26-year-old in the persistent vegetative state said he would never want this, and they say, let's stop, that's acceptable. If they say, no, he would want to keep going, he wouldn't want us to give up on him, he'd want to at least give him more time, then we can actually accomplish that. So we have to be careful in making sure that we don't assume that everyone's goals are the same as ours. And then there's kind of a bigger question of what are society's goals for medicine? How do we want collective funds such as Medicare and Medicaid dollars to be used for? Do we think it's a good idea to have long-term acute care facilities where people are on long-term ventilators? Right now, society seems to say, yes, that's acceptable. And we haven't really had a really robust discussion about that. But is prolonging death an acceptable goal for medicine? Because certainly we see that too every day in our ICUs. And finally, I'll leave you with this thought. Atul Gawande said, in stories, endings matter. Endings are not entirely controllable, but we are not helpless either. The chance to shape one's story is essential to sustaining the meaning in life. And I will now turn it over to Dr. Namm.
Thank you, Grace and Gina. So I think Dr. Wee and Dr. Mohr really eloquently kind of laid the foundation of what the problem and what the challenge really is that we're facing as clinicians, and intersecting with these patients and families at a really crisis moment in their life. And there's not going to be all good, happy outcomes, as we all know. That's why we're here discussing this. But I want to try to provide just briefly some tools that we can use, that many of you I know are already using, to approach these difficult situations. And so in clinical ethics, kind of a well-established model to look at each case holistically, and to consider all the different aspects of ethics is the 4-box model. And really looking at medical indications, as Dr. Wee could allude to, what is indicated, what is not indicated. Patient preferences, which is really respect for patient autonomy, and quality of life issues. So, which is what Dr. Mohr was alluding to. What will you be willing to go through to achieve a little bit more time or a possible chance of cure? And then there's contextual features as well. As Dr. Wee mentioned earlier, a little bit about the cost. What's the cost of the treatment going to be financially to the individual, to the family, or to the system in general? And there are also religious and cultural issues that we need to be mindful of and respect as well. But it's really the medical indications, it's really us as clinicians, medical team, nursing staff, what is really helping, what is harming the patient. And then in terms of patient preferences, a lot of the times in the ICU and in end-of-life situations, it's the surrogates who are, hopefully practicing substituted judgment. And so it's difficult because we may not know exactly what the patient would have wanted if they have not spelled it out very clearly in advance directive, which is is very uncommon. And then there's quality of life issues. Really is where I think the rubber meets the road. And that's where the communication, the shared decision-making takes place. And a lot of that also is dictated by societal goals and norms, as Dr. Mohr alluded to earlier. And then in terms of the final box, the contextual features, we try to avoid, considering these aspects at the bedside. We try to avoid placing this burden on the clinician or the medical team. And so really, an ideal situation, this should be kind of written into the policy and the law in terms of directing us how to proceed, considering these aspects. But really, I think the big take-home message that I want for all of you to just remember is that in terms of good outcomes in medicine, we know that it relies heavily on what we call the therapeutic relationship, and that really is centered on trust. It's simple to say, and it's hard to practice in every situation. I think historically, back, during the time of Hippocrates and maybe before, society has entrusted the medical profession, and a profession is any kind of group of individuals with a specialized skill that they have, and society gives them the opportunity to perform these with some or little regulation, knowing that they will kind of regulate themselves to make sure that they're doing what's best for society. But unfortunately, over time, historically, we in the medical field have eroded that trust. Maybe not individually ourselves, but just over time. And this is a kind of a landmark paper from Johns Hopkins, looking at, surveying different races and looking at how their perception of the healthcare system is. And you can see that between white patients and non-Hispanic Black patients, there's a significant distrust in hospitals. distrust in physicians. And there's a higher belief that the hospitals may deceive or mislead patients and families. And we know historically that experimentation has been done on minorities and those who are kind of more vulnerable populations. But many believe that it's still ongoing without their knowledge. And so this is really what we're up against when we're facing our patient populations, and it's magnified when it's end of life situation. So really it's our goal, it's our job collectively, but also individually to rebuild and nurture that trust. And that's really one of the big initiatives of the American Board of Internal Medicine and larger professional medicine as a whole. So how do we build that trust? And it really comes down to communication. I mean, many of you know this. Those of you who are married or in a relationship know that communication is very, very important. And it can help and it can drastically hurt the situation. What I want to really emphasize is that the communication style is equally as important as the actual information that is being communicated, right? And so I think a lot of times as physicians, as nurses, as students, trainees, we give them the information, which is true, but how we communicate it, for whatever reason, is not received well. And so I think just a quick reminder to be cognizant of our nonverbal communication. Eye contact, you know, our arms folded or legs folded, that kind of shows we're more closed off and less open. You know, is our pager going off? Are we distracted by our phone, et cetera? So those things, and obviously in this situation with COVID, where we can't always meet face to face, and it can pose a lot of challenges. But we do not know that effective communication has been shown to positively influence health in many different metrics. And we know that miscommunication can have severe negative implications, and also, you know, not only reducing patient satisfaction, but you know, compliance with medical therapy and reducing levels of patient hopefulness and trust. And so really we need to work on improving and optimizing our collaborative communication, because really that's been correlated with greater patient satisfaction, loyalty to the physician, trust in the medical system, and ultimately will lead to improved outcomes for them and society as a whole. So how do we do this? Seems like some, like Dr. Mohr, Dr. Wee, are just naturally gifted, and they can just, you know, spout out magical phrases that that convince patients and families to kind of do the right thing. But in reality, it just takes practice, and there are evidence-based scripts that are available. Dr. Mohr mentioned Atul Gawande. So out of his lab, Ariadne Labs, there are published scripts, and this is just one example. It's a serious illness conversation guide. And this is really discussing, you know, with the patient directly, but this is definitely applicable for, you know, discussing with families, surrogates in the situation. And really the main take-home message in this conversation guide is really 4 basic steps. Is number 1, ask permission to talk and discuss. A lot of times patients and families are overwhelmed with all the bad news they're getting every day. And then they just try avoiding, you know, having these conversations. But setting up an appropriate time, asking permission, it really shows that you are siding with them and trying to support them. And then secondly is really seek to understand them first before we burden them with all the medical issues and the poor prognosis that is going on with their loved one. Really understand what their goals were, what the patient's goals were, any conversations that they had, and how they want to kind of proceed going forward. And then once we understand, then we really explore kind of where they're at and try to help guide them through this treacherous path. And I like to use the 3 W's when kind of phrasing and bringing up these touchy and difficult topics. Number 1, I worry. I worry that, you know, your loved one, you know, may not be responding to the pressors or the antibiotics. And number 2, I wonder. I wonder if their loved one would want to be in a situation like this, you know, if they were going to be intubated for a prolonged period of time. And again, that's it just brings up the suggestion. It doesn't mean that that's what you want to have happen for this patient, but it starts getting the family thinking about, well, maybe this is happening. If that were the case, what would my loved one want to do? And then finally, I wish. And there are many requests that we may get for the patient that we just can't fulfill, or it's not medically indicated, or just inappropriate. And in those situations, I wish really sets up a stage where we would want to do something if we could, but it's just not possible in terms of the limits of medicine that we have at this time. And it still tries to keep that trust and that alliance that you have with the family and the patient, yet communicating with them that there are some things that we can't do medically. And then finally, just support a shared decision. And they, as was alluded to earlier, majority of the time, this is not going to be resolved in one conversation. It's not one family meeting, but this is a process. The earlier that it started, the better, and we build on that relationship. So I want to leave some time for discussion and questions. So I just wanted to end on this, moral distress. This comes up, it's real, and it affects everyone in the medical team, from physicians to nurses, RTs, the staff, the students, the trainees. It's very common in these types of situations where potentially inappropriate therapy is being prolonged. We worry about, is the patient suffering needlessly? Are the family's expectations unrealistic? And really, moral distress is when a person recognizes a moral problem, but is unable or feels constrained from acting on it or resolving it. And it causes physical manifestations, like upset stomach, headaches, stress, anxiety, insomnia. And it's a real issue that can lead to burnout and can lead to decrease in staff and in medicine. There's another term called moral residue, and those are lingering feelings that each of us carry from those times when we faced moral distress and we felt like we have seriously compromised ourselves or allowed ourselves to be compromised. And there's a famous quote in surgery by a French surgeon back in the turn of the century, 19th century. But he says, every surgeon carries within themselves a small cemetery where from time to time they go to pray, a place of bitterness and regret, where they must look for an explanation for their failures. And I think as a surgeon, which are the shoes that I kind of am in and have definitely been through this, I know intensivists and those in the ICU, it may even be more difficult because you most likely have not had the luxury of having a conversation with the patient before they arrive at your door and really know what their goals were, right? And so it's a lot of the time it's a guessing game, and we say, what would we want to do? And we have to trust the family that really they're making the best decision for their loved one, whether we agree with it or not. But some practical, maybe suggestions for dealing with moral distress or moral residue. Again, a lot of the cases that were presented are classic cases that are known causes for moral distress, but it can result from delayed or incomplete end-of-life discussions. For instance, patients who are on ECMO with kind of bridge to nowhere, so to speak, or delayed or poor decision-making, specifically in unrepresented patients. Fortunately, here we have a policy, a P23 policy, that helps us navigate through that a little bit more expeditiously. But it could be due to medically inaccessible care, which many of us faced head on during the COVID pandemic in terms of allocation of scarce resources. And then medically inappropriate care. This patient is still full code, but they're on 4, going on 5 pressors. Is chest compressions really going to help this patient? And then miscommunication, whether it's death by neurologic criteria, whether it's due to cultural assumptions, whether it's based on our own personal biases that we need to reflect on and try to identify as well. And then it's always difficult to deal with grieving family members, especially if the patient is young. It's very difficult for families to come to grips and let go. But in terms of some practical tips, evidence-based interventions, number one, debriefing. I know it's something that many of our critical care colleagues do, which I'm very appreciative because my residents come and tell me that a debriefing was done and it was very, very helpful. I mean, they are also carrying around this baggage and this weight on their shoulders, and they have to go and take care of the next patient that needs their help. But debriefing is very powerful and very, very important. An ethics consultation service, which is available here at Loma Linda 24/7. Please, we want to hear if there's any way we can help. And don't worry if it's in the middle of the night, there's always somebody on call. Hopefully we'll be awake to answer your page, but there is someone available 24/7. And then reflection. And we have here multiple resources, whether it's mindfulness or in our School of Psychology. There's Dr. Rechka does training in community resiliency model, which some of you have done in critical care, but really building our own resilience to withstand these moral distress times. And then finally, Schwartz rounds, which we do regularly. It's a time where we can come together as a community and share kind of our experiences and know that we're a part of something bigger. So with that, I want to save some time for Christian Johnson. So many of you know him well. He needs no introduction, but he is one of our general counsel. And really, I think one of the issues and concerns that many of us face in these situations is, what kind of support will we get from a legal perspective, and what kind of protection from the institution will we get if, we potentially are going against family wishes, but know that, we are doing the right thing medically. And so I want to turn it over to Mr. Johnston, and thank you for being here. And I'll turn it over to you.
Good afternoon, everyone, and thank you, Dr. Namm. So ending with a quote from Renee Lariche like that is quite the downer. Thanks for leaving that for me, but we'll just I should have had my own demotivational poster like Dr. Wee had. My favorite one actually is a picture of the jury pool. I don't know if you've seen that one. It has a jury pool, and it says, just remember, when you go to court, you're putting your life in the hands of 12 people who couldn't get out of jury duty. So that's kind of where we're at here. Let me just make a couple comments, and then we'll open it up for questions. First, no matter how good your lawyers are, we're not going to keep you from getting sued. As you realize, as a physician, you can get sued for just about anything. The question is whether or not they can win. And so the question you'll often hear from one of us when you're asking us this question, do I have to comply with this family wishes, is you tell me, doctor, what's the standard of care here? Because that's the standard you're going to be held to, and that's the standard that the defense will apply. Now, as far as whether you are required to do everything the family asks, intellectually, I think everyone here knows you of course don't. The California probate code, which we don't all just read, as bedtime reading at night, so you may not be familiar with it, but it was referenced earlier on in this presentation. But it is pretty specific on this issue. It does say, I think it's section 4735 that was quoted, that healthcare providers are not required to adhere to healthcare instructions of their patients that are contrary to generally accepted standards. That's really generally accepted standards of care. So one of the things we'll often ask you, and some of you have been on the phone with me as I go through the healthcare team, and I at least want to know that our entire team is on the same page. Because the way that we lose cases, the way that you are said to have not complied with the standard of care, there's only one way, and that, because we can't take those jurors and put them through medical school and residency and fellowship and get them some experience to make experts out of them. The only admissible evidence as to what the standard of care is and whether or not you complied with it is going to be expert witness testimony. So another physician is going to have to come testify. And they're out there, they advertise. There's some, we had an emergency medicine physician who hadn't practiced in 30 years, but had made a career out of testifying only, that came to testify against us in a pediatric intensivist case. So they're out there, and they will testify to whoever is willing to pay them. And we have special names for those people, but this is a polite audience, so I will keep those to myself. All that to say is, what we're looking for is whether or not you have complied with the standard of care, and that's the standard that the probate code puts before you. It says, no, you do not have to do everything just because a patient's family says to. Where I think people get in trouble, frankly, in some of these issues, is where we sacrifice our clinical judgment. And I'm saying we sacrifice our clinical judgment, but I really mean you. I'm just trying to make it nice sounding. You sacrifice your clinical judgment for the sake of peace and calm on the part of your patients that are whining and complaining. Do this, do this, do this. And you say, I shouldn't be doing that. But you do it anyway because they demanded it from you. And then something goes as you anticipated it might go. And then you get sued for that. And then that expert comes and says, well, the standard of care certainly would not have somebody do that. So when the code does say, here's what you do when you decline to provide the treatment that's demanded. You have to inform the patient of that. You have to make reasonable efforts to transfer the patient. And you do have to provide continuing care until it becomes clear that that patient is not going to be transferred. No one's going to accept that patient. And then we still have to provide palliative care, the continuing care as we normally would for those patients. And I think I will close my comments right there and go to the questions and turn it back over to Doctors Namm, Wee, and Mohr.
Thank you so much. Really appreciate that. Yeah, so please, questions. There was a question, Dr. McCluskey. I don't want to put you on the spot, but you had put a question in the chat. We've had a couple of answers to the chat, but please feel free to also pose your question out loud.
I get the privilege of sitting in on some of your committees as a guest and a learner. So I've heard some of the comments where an opinion is rendered, like I guess the easy one to reference is dialysis. And the written document as well as the verbal communication seemingly tends to be either or. It is ethically permissible, I'm learning your language better, to do either is kind of the way it ends up being presented. And then I've heard you as a team digest what happened with some surprise sometimes. Well, I was surprised they did do dialysis. And I think as someone that spends most of my time in the trenches, we often are looking for a backstop to the comments about consistency, making sure there's team agreement. Sometimes what we need, it seems, is maybe a multidisciplinary affirmation that it is time to not continue some of these relatively desperate measures. That's what I was alluding to. So involvement of ethics, I've heard, I know you've heard it on the ground level, sometimes a frustration, and yet when I'm involved in your meetings, there's actually an expression, well, you're expecting something we weren't going to render in the first place.
Let me add to that, just because Dr. Namm asked me to say what would legal support, what kind of support would you get? You'll often get a question from legal, have you already taken that through an ethics consult? And sometimes you have, and sometimes you haven't. And then you go through that discussion, and then you say, this is what I'm planning to do. And many times the response from legal is, okay, doctor, we can support that. What you want to listen for is when legal says, that's going to be very difficult for us to defend. We can't, or we don't often say we can't support that, but often we will say, yes, we can support that, which usually means you've got the institution and your risk management and your legal team behind you. It doesn't mean there's no risk of somebody complaining. But it says we've done what we can support that direction. But often as we're getting to that, we do want you to run it through that legal ethics, that ethics consult, because that does help with a couple of things, helps you think through the ethical issues. But it also, and I don't think we've discussed this here, often helps on the communication part with the family. And there are some resources there that I think it's wise to avail yourselves of.
Chris, I think that's really helpful, and thank you for stating that. And I would say our ethics consults are similar to that. When we say it's ethically permissible to not offer dialysis or to change code status to do not attempt resuscitation, I think we're saying we support you in that, and maybe even we think that's the right thing to do. But we would never say, if you think that coding this person is going to be helpful, we would never say, oh, you shouldn't do it. So whenever we say it's ethically permissible, we support you in that. But if you think that this is going to be a beneficial intervention, that's okay too. I have had a couple of cases, I'll tell you, in ethics consults where, interestingly enough, it was kind of opposite. The family, speaking on behalf of this patient who'd had a big stroke, said he wouldn't want certain things, and the team felt like they should keep going. And I said it would be ethically problematic to force interventions on a patient when his advance directive and his family is stating he would not want those things. And that if the team did not feel comfortable doing that, they needed to change his team of caregivers to someone who did feel comfortable honoring his wishes. That's again rare. That's not what we often see. It's usually the team saying, do we have to do this? And the family wanting more. But every now and then we see a family saying, let's stop this. We don't want any more.
One other observation on the teams. When you make a hard decision, when you get to that point, you want to make sure you've communicated to the handoff team, because something that makes it very difficult for us is, okay, but all those people that worked on that for a week now went off service, so we're starting all over again. And it's not just because that's hard to defend; it's because that's difficult for the patient, and it's really hard on your staff and your teams.
Thank you very much for this presentation. Much needed. In fact, I'm glad we're recording it, because we will probably use it for further education of our faculty, even residents that are rotating through the ICU. It is important for us to make sure that we do that consistently. As I was listening, I had two comments that one that flagged me as Dr. Namm was speaking, and another one is an observation that I've had over the past year or so. The background is we're very different from a generation perspective, from a cultural perspective, and what we term as norms and are comfortable with can be different from one individual to the other. But one of the thing that struck me with Dr. Namm's presentation, and I totally agree with him, is that the mode of communication, the first bullet point, makes a big difference. And I agree with that. Not all of us in the ICU realm communicate the same way, and not all of us are effective, okay? And so to a certain extent, we need to invest the time needed. I know SSCM does provide a course. I attended it a few years back, as into how to deal with end-of-life care issues, okay? Because the mode of communication and our expectation and our sometimes expectation, not just of our colleagues, but of our patients and their family and their mandate to understand what I'm saying, is extremely sometimes detrimental to the conversation. So the mode of communication, especially the first one, Chris was saying handoff is important. It is really hard when you come in after a week of, I would say, non-optimal communication and trying to make it optimal, okay? Cannot do that. So that's one comment I would want to put really quickly, and encourage my colleagues across all specialties to invest the time necessary for that extra training because it doesn't come in medical school. Okay. Number two, something that I'm always concerned about, and I've seen it. Thank God it's not as common in Loma Linda, but it does happen even in the setting of Loma Linda. Please, let's not confuse acuity with terminal. Okay. A very, very sick patient does not mean he's moribund. Otherwise, we will not try on more than half of our patients that hit our ICU doors. Okay. I've often told my residents, multiple years back, if Kathy Gifford, I'm not sure if everybody knows who Kathy Gifford is, shot in the head, did present to Loma Linda multiple years back, would she have survived to the extent that she has survived now, to the extent of the function that she has now? I'm not sure of that question. I am not sure the answer to that question because sometimes we confuse acuity and terminal. And when we review some of those cases in QI and I see some of the discussion goes, okay, well, was it appropriate? We had a discussion with the family and the family didn't want to do anything. And my often question, and my colleagues will remember this, what was terminal about this patient? Why did the conversation with the family lead out to we don't want anything done? Okay, it was an acuity, high acuity, but there's a way to communicate to the family too. And again, going back to the first point, is if we ask a yes or no question, you'll get a yes or no answer. Do you want me to do anything? No. Do you want me to do anything? Yes. Okay. Versus your mom and your dad is very, very sick. They just got shot in the head. But allow us some time to work with them, and let's see what sort of outcomes we get in a limited amount of time. But so these are my two brief comments. I appreciate the presentation. It's recorded. Marquita, please keep it because we're going to use it for orientation. But please, I think the way we communicate the first time is integrally important. And let's not confuse acuity with being terminal.
I think just to respect everyone's time frame here. I know lots of people have other appointments. I want to thank the team for their presentation. It's highly needed topic. In non-COVID times, I'd welcome you all to the workshop that follows for the afternoon with food to be served. Maybe next year we'll do that. Any wrap-up comments from the team?
Just one last comment, Dr. Chuldian, I really appreciated your comment here. If the medical team believes a therapy to be futile or medically ineffective, why should they initiate it in the first place? I would agree with that. I also would agree that when a therapy appears to become medically ineffective, it is ethically and legally similar to stop a therapy as well as initiate it. So that's just the last point to bring up there too.
Thank you all for attending. Take care.
Thank you.